Welcome to today's conference call. Using self-measured blood pressure monitoring to diagnose and manage high blood pressure. My name is Hilda, and I will be your operator for today. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star and then 1 using your touch-tone phone. And now I would like to turn the call over to Mr. Ashley Green. Mr. Green, you may begin.
Thank you so much, Hilda, and thank you everyone for joining us this afternoon. I'm Ashley Green. I'm a Quality Improvement Project Specialist at Metastar here in Madison, Wisconsin. And along with our two sister sites, Stratus Health in Minnesota and Impro in Michigan, we make up the Lake Superior Quality Innovation Network. And we're all very excited to have you join us today. Just a couple of quick housekeeping items before I introduce our speaker. We certainly encourage any questions that you have, and as Hilda mentioned, we'll save a few minutes at the end of the presentation to take those. But along the way, if you prefer to put those questions into chat, that's fine as well. I'll help Linda monitor those, and we'll be sure to get those answered. And then at the end of the presentation, if you wouldn't mind taking just a couple of quick minutes to answer an evaluation for us. It's a great way for us to get feedback, and it helps us really improve our series of offerings as well. So we appreciate your time with that. And so I'll introduce our speaker, Linda Murakami, who's a Senior Program Manager for Quality Improvement in the Department of Health Outcomes at the AMA. And in this role, Linda provides leadership and technical expertise to primary care teams by conducting evidence-based quality improvement coaching. Prior to joining the AMA, Linda directed quality improvement programs in the ambulatory and home health settings. She was also the administrator for a home health agency in the Chicagoland area where she led operational, quality, outcome, and compliance activities for the organization. Linda has a clinical background as a registered nurse with a focus on the medical oncology patient population. And so with that, thank you so much for joining us today, Linda. We'll turn it over to you.
Great. Thank you, everyone, for joining me today. And this slide just lets you know that I don't have any disclosures. Our objectives for today will be to explain the benefits of using self-measured blood pressure, SMBP, list patients for which SMBP is indicated, demonstrate how to train patients to self-measure their blood pressure, and explain how to interpret the SMBP readings, and describe how to set up an SMBP program in your practice. So here's really the case for SMBP, why we feel like we need to do this and do it well. We want accurate, representative blood pressure readings. They're needed to make sound clinical decisions, and they're more likely to represent a patient's true blood pressure than a single office blood pressure reading. And as you listen to this presentation, you'll understand why there is a difference. So let's get started by discussing what self-measured blood pressure is, or SMBP, and how we can be beneficial. So SMBP, it's when our patients perform their own blood pressure measurements outside of the clinical setting. It's beneficial because they're able to better predict future cardiovascular events as opposed to a standard office blood pressure when we're just getting that one reading and we don't really have any history of a trend. So we'll talk later about communication, but we always want to make sure your patient has instructions on how to get the results of the readings to the office. And always make sure the patient knows what to do if they get a reading that is dangerously out of range, such as, call the office, go to an urgent care, or instructing them to go to the emergency room if it's after hours. So let's talk about why you should use SMBP in practice. In order for SMBP to be beneficial, it's best when paired with clinical support. And there's a process for clinicians to receive the SMBP readings from the patient. SMBP works to improve blood pressure even when just used alone, but there's lots of evidence to support that. But there's even stronger evidence telling us that when SMBP is combined with additional support, it can be even more effective in improving blood pressures. Additional support includes counseling, providing patients with education about hypertension and their medications, or even, communicating online through the patient portal regarding their blood pressure results and providing guidance. All of that be considered additional support. And, these actions really help self-measure blood pressure even better because we can react in a timely manner to the results that they're giving us. So there's always a few ways that SMBP is used. First, it's accepted as an out-of-office method to confirm a diagnosis of hypertension, and that's based on USPSTF guidelines. It's based on AHA, American Heart Association, American College of Cardiologists guidelines as well. They want that out-of-office blood pressure in order to confirm that blood pressure in the office really continues to be high. It's also used to monitor the effectiveness when titrating your medications, especially in conjunction with telehealth counseling or other clinical interventions. And then next, SMBP is used for patients who are placed on antihypertensive medications for the first time. Again, this should be, combined with additional strategies like telehealth and team-based care to increase effectiveness. And, in this evidence, you can find it in the 2017 ACC-AHA guidelines. So here's how SMBP improves the maintenance of blood pressure. In 2015, the Australian expert consensus published that home blood pressure measurements can help assess the antihypertensive treatment that's being used. And the study found that therapy guided by home blood pressure measurement compared to usual care based on office blood pressures, it led to significantly more patients achieving blood pressure control and larger blood pressure reductions. So when we talk about assessing control across a 24-hour period, SMBP offers the opportunity to assess treatment effects at different times of the day and over extended periods of time. So the convenience of SMBP for patients is particularly helpful for repeated measurements. And treatment decisions are based on the average of the series of readings taken. So you take all the readings that the patient gives you, usually it's for like a 7-day period, and you average your systolic and diastolic. The patients taking their blood pressure should be informed that pressures may vary between their measurements and not to be alarmed with a single high or low results on a single occasion unless the results persist or are associated with clinical symptoms like chest pain or shortness of breath. And SMBP has advantages of engaging and empowering patients in the management of their own blood pressure. In patients with a diagnosis of hypertension, patients may take part in their own blood pressure management just by monitoring their blood pressure. So when they follow the treatment plan and take their meds and watch their diet, they'll see improvements in their blood pressure readings. But they'll also see their readings get worse if they decide to stop taking their meds, which we hope inspires them to get back on track. There was a meta-analysis by Fletcher in 2015 that concluded an increase in medication adherence was best seen in studies using objective measures like electronic monitoring, pharmacy refills, and pill counts. But adherence was found to be at 97% in the group using self-measured blood pressure compared to 88% in the control group. So the literature tells us home blood pressure monitoring is comparable to 24-hour ambulatory blood pressure monitoring, which is considered the gold standard for taking blood pressure, especially outside of the clinical setting. So 24-hour ABPM is where they wear a blood pressure cuff on, and there's a little device connected to them, and it takes their blood pressure every 15 minutes or so, 24 hours a day, no matter what they're doing. And you can, make it take blood pressures a little further apart during sleep as not to disrupt them, but you also get those nighttime sleep blood pressures. And so, but compared with clinic blood pressure, home blood pressure monitoring has stronger associations with hypertensive target organ disease, as well as being a better predictor of cardiovascular events and mortality. So, the study cited here, there's a footnote at the bottom, states that there's several areas that home blood pressure shows more clinical dynamic than BPs taken in the office setting. For conditions like all-cause mortality, cardiovascular mortality, left ventricular mass index, all of those things. For silent cerebrovascular disease, which includes silent brain infarcts and MRI white matter hyperintensities, and different cerebral microbleeds. SMBP was able to show a better cause and effect to those conditions. And SMBP can help reduce the number of medications a patient needs. It can decrease therapeutic inertia and improve blood pressure overall. Therapeutic inertia was more likely among 60-year-olds and older, those patients. And just as a reminder, therapeutic inertia happens when you have elevated blood pressures, but you don't do anything. So it could be actually for any medical condition where no action is taken, is considered therapeutic inertia or clinical inertia as well. One study asserts that if in-office clinical inertia decreased from where it is now at about 86% to 66%, blood pressure control would rise from 46% to 65.9% in 1 year. Additionally, one study showed a decrease in systolic blood pressure by almost 13 millimeters of mercury when using self-titration and telemonitoring. So as I mentioned previously, SMBP is useful in diagnosing suspected hypertension, but also, white coat hypertension and mass hypertension. The 2017 ACC/AHA guidelines, hypertension guidelines, provides us this guidance. So you can see with white coat hypertension, if you have that untreated systolic blood pressure is greater than 130 millimeters of mercury, but less than 160, or their diastolic is greater than 80 or less than 100. And then mass hypertension is for those patients who have normal blood pressures in the office, but are high outside of the clinical setting. So these adults with untreated office blood pressures, you can see them consistently at about 120 to 129 millimeters of mercury for systolic and 75 to 79 for diastolic. So in the office, people might ignore that, but somebody having consistently sort of elevated blood pressure like that, we want them to take home blood pressure monitoring, and then you might be able to identify that the blood pressure is higher outside of the office, thus the mass hypertension. So we touched earlier on how SMBP can increase patient engagement when we talked about medication adherence. We also discussed how it can be used to monitor the effects of any changes to treatment regimen, such as increasing medication doses or adding meds, or even when the patient implements lifestyle changes such as diet and exercise. Patients and providers benefit from seeing the direct effects of these interventions through the SMBP readings. Again, the 2017 hypertension guidelines suggest using SMBP to determine if treatment-resistant hypertension is present for patients with difficult to control pressures. A study done in 2011 with over 8,000 patients found that about 37% of those patients thought to have treatment-resistant hypertension actually had white coat hypertension after having out-of-office blood pressure monitoring performed. So this is important as misdiagnosis could lead to overtreatment with the potential for patient harm. So here are a few barriers that are common concerns. Providers are concerned about the cost of the devices for the patient, but also the cost of unreimbursed time to train patients on SMBP and review the results. So use of allied health members of the office team can reduce the cost incurred for training. And also note there's going to be CPT codes coming out in January of 2020 that would help with some of this time spent in being able to bill some of these costs back. Many clinicians also verbalize they are not aware of protocols for SMBP, which is why they're working, or why we are working hard to provide these resources online to providers and their teams. And there's also resources available to teach clinicians how to train their patients. And health literacy comes into play with provider concerns about valid data, measurement technique, use of validated devices, and patients cherry-picking results to provide back to the office. Again, proper training protocols, use of validated devices with memory in them can help alleviate some of the barriers. Especially you have them bring back the device into the office, you'll be able to see their history of results.
Linda,
let's talk about developing, yes.
Sorry to interrupt you. You had a question there about devices from Ann, and I think you may have a slide on this, but I just wanted to bring that to your attention. So what brand of devices are used in the office as well as digital monitors?
Yeah, we can't endorse any products at the American Medical Association. There are lists. I'm not sure. I might have them in here on the Canadian Canada Hypertension, look for that website, and also the British and Irish Society of Hypertension. They've got devices listed on their website. I think the British and Irish Hypertension Society has a pretty good extensive list. And then the AMA and the American Heart Association later this summer, I believe, will also have validated device listing on a website coming up. I will say that, we've seen in the clinical study a lot of people using validated Omron devices for blood pressure monitoring, as well as Welch Allyn in the clinical setting. At home, there's a lot of also the Omron home devices. The prices vary. You can get the older models as long as they're validated and the newer ones. And always remember, with more bells and whistles, it's going to cost more money. And I think there might be a slide on that. So let's talk about some things to consider when starting that SMBP program. So it's always preferred to have the clinical team work together to make changes to the organization's processes, but you always need to identify someone to champion the efforts of the team. And many times it's a physician, but it can be any other provider who has decision-making authority to move suggested changes through the practice. We mentioned here budgeting for devices. So again, financial consideration will be needed on behalf of the practice if you want to set up a loaner program. So this is when the practice will buy home blood pressure monitors that they keep on site and loan to the patients. This program helps where patients who may not be able to purchase their own device can still benefit from performing SMBP for a shorter period of time. It also benefits those patients the provider is working with and ruling out a diagnosis, so they don't have to commit to purchasing a device if it's determined that they don't have hypertension. Hang on. Oh, there we go. I was a little stuck. Sorry about that. So, the times for the information here is approximate, but it will give you an idea of how much you need to build through the program. So you want to train your staff on how to do self-measure blood pressure so that they can properly train your patients. So about an hour. Patients take about 5 or 6 minutes. It depends on, again, their literacy level and their learning capabilities, maybe a little more, sometimes less. Ensuring patient accuracy if the patient uses their own device, it takes about 5 minutes. Averaging and documenting, maybe 5 minutes, and then preparing the device for the next patient. Again, this is for the loaner program. If you're going to do that, it takes about 5 minutes because you want to check the device, make sure it works, and you need to disinfect it. Okay, so here's some additional tips to consider so you can allocate the work among your clinical team. So not all patients will need to use self-measured blood pressure, so if you want to create a process to identify them. And then also consider whether a patient is willing or able to do the measurement, because if they're just outright not going to do it, don't waste your time. But next, select trainers from the team who make sure there's consistency on how the patients are taught to perform SMBP. And also make sure you create a process for the patient to communicate the readings and any other concerns to the office and how to manage the return of equipment. Usually the staff member receiving the readings from the patient will average and document them into the EHR and notify the provider who's in charge of titrating medications of the results. And the timing for scheduling follow-up depends on the length of time you're having the patient perform the SMBP as well as what the results are. So if they're doing well, they're maintaining, maybe every 30 days, maybe every 6 months is fine. But if you're in the middle of working with the patient and trying to get their meds regulated, about every 2 weeks would be recommended, no more than 4 weeks for returning to the office. But definitely 2 weeks is the better choice. So there's some important factors to consider when starting a loaner program. After you determine how you will select patients to receive the devices, you need to set up processes for tracking them, including when they'll be returned and where they returned. Loaner programs need to be sure that equipment is disinfected following the CDC guidelines for cleaning small equipment. Plus, you'll need to delineate spaces for dirty and clean devices so they don't cross-contaminate when brought back into the office. Often a plastic storage bin will work to hold the dirty devices until they're clean, and then you can place them in a clean bin or put them in a storage cabinet or on a shelf to get them sent out to the next patient. So patients with a confirmed diagnosis will use their device long term, so purchasing one or owning one of their own would work best. As I mentioned before, for patients without a diagnosis, loaner devices might be a better option, especially if the patient does not get diagnosed with hypertension. So incorrect cuff size is the #1 error when performing blood pressure measurement. This is with home blood pressure monitoring as well as in the clinical setting. So the most accurate way is to use a tape measure to determine the circumference at the midpoint of the arm between the acromion process of the scapula and the olecranon process of the elbow. So you find that midpoint, flip the tape measure around and do the circumference. That'll tell you exactly what size, or guide you to exactly what size cuff you need to use. So there's 4 main validation protocols for blood pressure devices. And while the 4 organizations use different protocols that vary in complexity, be sure to instruct patients to only buy devices that are validated. This information might be on the box or on an insert, or can be researched online. Also ensure they buy an automated upper arm device, preferably one with memory and averaging. Again, the technology on devices now also includes Bluetooth capability that transfers the readings from your blood pressure monitor to your smartphone. And like I said, the more bells and whistles, the more it's going to cost. But also, please do not recommend or have patients use a wrist cuff unless it's impossible to do brachial readings with an upper arm cuff. Only recently have manufacturers been able to develop wrist devices that could pass validation protocols. So we'll go over the wrist cuff thing later, but never use a finger cuff or finger devices. They're just not accurate. And when a patient does purchase their own device, have them bring it into the office to test the accuracy when possible. It used to be recommended you brought every device in to test it. We know that's a little unreasonable, so if the readings between the home and the clinical setting are way off, then have them bring it in just to confirm that their device is correct. So we suggest that every device be brought in, but like I said, you don't have to. And, if you do have time though, go ahead and have them bring in their devices, because we really do continue to suggest that whenever possible, test the accuracy. And the accuracy is done by taking multiple readings using the patient's blood pressure monitor, and then you use the offered standard method of blood pressure measurement. So even if you're using manual, blood pressure measurement, it's still okay. We just still need a source of comparison. So differences of less than or equal to 5 millimeters of mercury when averaged are considered acceptable and make the device safe to use. There's a gray area between the 6 and 9 millimeters of mercury difference, but do not have the patient use the monitor if it's greater than 10 millimeters of mercury of a difference, and that's when they should take it back and replace it with a new one. And then accuracy can be done on an annual basis. So you want a general idea of what your patients already know about self-measured blood pressure and about hypertension. You'll want to instruct them on when to measure and at what frequency. Taking readings twice a day before taking their blood pressure medications is recommended, and each measurement they should take 2 readings 1 minute apart. It's best to get 7 days of readings, but the guidelines state the minimum is 3 days worth of readings totaling 12 measurements. So we suggest telling the patient to take their blood pressure for 7 days, and if you're lucky, you'll get the 12 readings or the 3 days that you need. So patients need to know how to properly prepare themselves for measurement. They should avoid caffeine, exercise, and smoking for at least 30 minutes before the measurements. They should also empty their bladder if needed. Patients should sit comfortably in a chair, rest for 5 minutes before beginning the measurements. You should also show patients how to use the device and put the cuff on properly. The main things they need to know in regards to this are how to turn on the device, how to start the measurements, how to put on the cuff. And then also making sure the tubing on the cuff aligns properly in relation to their arm. Device manuals also have a page usually with specific error messages and solutions that can be helpful for them to refer to in case they do get an error. So make sure you show them that. You determine the designated blood pressure arm by taking blood pressures in both arms. So maybe this was already done in the clinical setting, but the arm with a higher blood pressure should be used for all subsequent readings. So if the difference between the readings in each arm happens to be 10 millimeters of mercury or more, you should notify the providers because there could be some other cardiovascular issue present. But also be sure to inform the patient that the cuff should always be placed on their bare skin. Proper positioning at home should be ensured just as we do it in the clinical setting. They should sit back with their back supported on a hard back chair, legs uncrossed, feet flat on the floor on a flat surface like the step stool if they can't reach the floor. Their arms should be resting on a table or a firm surface, firm flat surface that is, and their palm of their hand should face up because it does relax the muscles in your arm a little bit. The middle of the cuff should be at heart level, which is about mid-chest. And there should be no distractions like using a smartphone or watching television. Patients should be shown how to document their blood pressure readings immediately after they're performed. We have a paper log that patients can use to document their blood pressures, which I'll show you in a little while. It's also important that patients know how to do their blood pressure, or what to do if their blood pressure is too high or too low or experiencing symptoms, like I mentioned before. Health settings may choose to standardize these instructions across the setting, or you can individualize them for each patient. But the patient also should be told how and when to communicate the results back to the practice after the week of measurements is complete. This information could be relayed over the phone, can be faxed, sent via patient portal, or you can bring a hard copy to the office. There's many options for relaying this information, but it's important to get a plan in place before the patient leaves the office so the provider can receive the results from the patient to use for medical decision making. Lastly, we want to recommend asking the patient to teach back the information we just covered and perform a return demonstration. So this can be done by saying something along the lines, I know this was a lot of information we just covered. Tell me what you're going to do when you get home. And this provides you an opportunity to ensure the patient understood the information you gave them and provide any clarification. So this is a great tool for patients to use to show them how to measure their blood pressure at home. I'll be giving you a website at the end where you can download this tool and all the others towards the end of the presentation. We talked about wrist devices. They should only be used on patients who cannot be fitted with an upper arm device. This is supported by the most recent hypertension guidelines as well as a recent scientific statement from the American Heart Association that was put out in March of this year. So make sure the patient places the wrist properly on their wrist, and you can also want to make sure the device stays in proper position because sometimes when they're moving the arm, it might cause problems and it might move. So like when you're positioning and they flex their wrist, so you want to make sure they're in that optimal position. It almost looks like they're saying the Pledge of Allegiance. Accurate readings are only obtained if the wrist is at heart level. So they might be too high or too low if the wrist is above the heart or below the heart. So if the wrist is too high, it's actually going to lower the blood pressure, and if it's too low, it's going to raise your blood pressure falsely, and so you're going to be treating off of incorrect blood pressures. So this instruction sheet's also on that website I'm going to give you. You also want to make sure they're resting their elbow on the table comfortably, so they're not engaging their arm muscles while they're taking their blood pressure. So you always want to make sure the patient has an established method for communicating. This can be done through the phone calls, the fax, the portal, and so on. And if they have that memory in the device, you can also have them bring it in and review the memory. For treatment purposes, like I said, you want to average those readings. So take all the systolic, average them together, take the diastolic, average them together, and that's what the provider should be using as their treatment blood pressure. So here's a table, and this kind of guides you on how to manage the results from self-measured blood pressure. This is using the JNC7 definitions for classifying blood pressure, using 140/90 as the marker for hypertension. And then this table provides the 2017 American College of Cardiologists and American Heart Association definitions for hypertension. So this guideline uses So this table uses the guideline that 130/80 defines hypertension. So self-monitoring was associated with reduced clinical systolic blood pressure compared to the usual care at 12 months on average of 3.2 millimeters of mercury. However, this effect was strongly influenced by the intensity of intervention ranging from minimal effect to self-monitoring alone on the average of maybe 1 millimeter of mercury reduction, but to an average of 6.1 millimeters of mercury reduction when the monitoring was combined with intensive support. So the reduction ranged from 3.2 to 9 millimeters of mercury with the extra support. So it's, calling those patients, discussing the results, giving them reminders to take their results or do their readings, and then reacting to those blood pressures as soon as they're available. So here's what clinical support can look like. You can develop a process for the one-on-one counseling. It can be using your pharmacists, the nurses in your office, or if you have health educators, community health workers, all of that can participate in the self-measured blood pressure program. And ongoing patient education can be done over the phone. It can be done in small groups. Sometimes people have classes back in the office after hours. In the clinical setting, or even in the community setting, doing similar education, bringing people together. And web and phone support has been found to be very beneficial. Secure sites like the patient portal is great for blood pressure and communicating results and communicating back to the patient. Automatic phone reminders to take the blood pressures and get the results back in. Texting, email, again, great ways to keep in touch with your patient. So we know there's a lot of patients who can't afford to purchase a device, and this is why we often recommend a loaner program. There's also times when manufacturers or retail stores will provide coupons or have devices on sale. Every Medicaid program is a little different, but we've been told that some states will pay for an automated home blood pressure device monitor. I happen to be presenting to you from New Orleans, and so apparently the Medicaid population here can get reimbursed for a home blood pressure device, so be sure to check where you live. And again, remember that those extra bells and whistles are going to drive the costs up. So Bluetooth capability is fantastic, but, don't push it on anybody who can't afford that extra $10. So prior to initiating, self-measured blood pressure, again, I'm just sort of reiterating that proper cuff size is extremely important. And a lot of cuffs only go up to large, the home blood pressure monitoring ones. There are devices out there with extra large cuffs, but because they're extra large, they need special tubing, or the device has to be manufactured a little differently so it can push that pressure through the tubing into the cuff properly and deflate properly. So just make sure that if you're going to get an extra large cuff, that it is the one provided by the manufacturer. We want to make sure that you have defined that treatment plan with the patient, making sure they know what to do with their readings, how to communicate them back into the office. And again, I know I've repeated this 3 times, but I can't stress enough. You want to make sure your patients know what to do if their blood pressure is too high, too low, or if they're having any symptoms associated with their blood pressure measurement, regardless of what the result is. So here's some tools and resources. First, this is the website that will take you to all the tools that I just talked about. It'll actually also take you to much of our other tools and resources regarding controlling high blood pressure. You're just going to have to scroll down and you'll find the ones for self-measured blood pressure. They're kind of listed alphabetically by category. When you open the website, there's going to be 3 tabs. Usually the media tab is the one that'll be highlighted first. So click the Downloads tab right there in the middle to the right of that, and that'll give you the list of all the tools and resources that are currently available on our website. Helpful hint, I learned this the hard way. You might want to right-click on the tool you want to look at and open it in a new window, because when you go back, it makes you start all the way over from the top on the wrong tab. So once you've established the Downloads tab, feel free to stay here. And we also have additional information for self-measured blood pressure on the website for Target BP, which is targetbp.org. So here's our best practices resource. You know, these pages I'm showing you on the slide are just snippets of what's on that page. So it lists the processes that you should follow to implement self-measured blood pressure, how you might meet that process, and the rationale for performing that process. For those who are planning a loaner program, these tools are useful. The inventory management sheet helps you track your devices. It tells you which device was given to whom, when it was given out, and when you should expect it back. It tracks the return date, the date it was cleaned, so you know it's ready for the next patient. And I also suggest testing the device when it's returned to make sure it's in working order before you send it back out as another loaner. And then this loaner agreement is a simple form that states the patient will take their blood pressure as recommended and bring their equipment back when planned. So this is not a legally binding document, although I did have a site recently state they were going to have it reviewed by their legal team to see if they can make it legally binding and hold the patient accountable financially if they didn't return the device. So the training checklist helps you make sure that you don't miss anything that's important for the patient to know or to have when doing self-measured blood pressure. The staff competency is a competency to make sure that the staff teach the patients correctly on SMBP and ensures all staff teach the patients the same thing regardless of who's doing the training. So you have an MA training the patient or you have your provider training the patient. They're both training the same way, teaching the patient the same information so you know what you're going to get back from the patient when they're giving you their results. The device accuracy test, which I mentioned earlier, guides you in checking the patient's home monitor for accuracy. You do the testing again against the usual method within the office. It is best done with automated devices as opposed to the manual blood pressures, but like I said, if that's how you do it in the office, then that's what you need to do. But it lists, you know, how many blood pressures you take with the patient's device, how many you do with the in-office device method, and then you take averages and compare the two results. Again, that blue infographic on how do you measure blood pressure is a great handout for patients. It tells them what to do before, during, and after they measure their blood pressure. It's a great tool for them to hang up in the area where they do their blood pressure, like on the refrigerator if they use the kitchen, or on a whiteboard or a corkboard or someplace in their home office. It allows you for 7 full days of measurements. There's also a place at the bottom right hand of the page for the clinical office to specify blood pressure that would require immediate attention if it's either too high or too low for the patient. And then there's the instructions for the wrist devices. Again, only use them if you can't fit an upper arm cuff. We want to make sure that those who do not need to use the wrist cuff can do so properly. And then the SMBP video can be used for training your patients. It tells them everything they need to do, including positioning, cuff placement, and recording their results. It's very succinct, and people seem to like it and use it for their patients. It's only 3 minutes and 45 seconds long, and it's available in English and in Spanish. So, Ashley, if there's any questions or if somebody has anything they want to ask?
Yeah, you bet. Thank you so much, Linda. There is, in fact, a question in the chat asking about the measurement of the arm, determining the correct cuff size. Is there usually a chart that guides the selection of the appropriate cuff, or how does that work?
Yeah, so you'll see then on the devices themselves, on the actual cuffs, depending on which one they're going to purchase, tells you how many, inches or centimeters would qualify for that cuff. So usually, like I said, home blood pressure monitoring cuffs, kind of go from, sometimes they'll do small, but definitely for medium, large, and some will extend a little bit into the extra large category, but not very far and not very often. So that's the best way to know, is to check the device itself, compare it to the patient's arm circumference.
Perfect. Hilda, do you want to remind our viewers how they can ask a question?
Thank you. If you'd like to ask a question, please press *1 using your touch-tone phone. If you'd like to cancel your request, you can press the pound sign or the hash key. And if you are using a speakerphone, we recommend that you pick up the handset first before pressing the numbers. Once again, for any questions, please press *1.
And, of course, if you prefer to use chat, here's your chance to do that as well. I did want to let everyone know while we're waiting to see if we have questions that I did post the link to Linda's slides in the chat section if you want to get those. And we also produced, as part of our hypertension control toolkit at Lake Superior, we have a couple of e-learning modules, and one of them covers SMBP. So if you're interested in that, be sure to take a look at that too. Yeah, let's see. Another question. I got it. It was a never mind. I think it was answered.
Yeah. Great. Oh, I did see someone's asking about the PowerPoint. Did you post that?
Yep, that's the link
Okay.
I just put in there for chat.
Great.
And also the recording of this webinar is usually available about a week or so afterwards on the Lake Superior YouTube channel. It's pretty easy to find. Any other questions for Linda? She's traveling, so I want to be respectful of her time as well. Hilda, any questions?
We don't have any questions by phone.
Okay. Well, certainly if you have any questions afterwards, you're free to contact me, and I can forward those on to Linda as well. Thanks again to our speaker, to Linda, for spending her lunch break in New Orleans with us today. We really appreciate all the information that you shared. Here's her email address, by the way. And with that, if there are no more questions, we'll turn everybody loose. And thank you all for coming today.
Thanks, everyone, for joining. Appreciate your time.
All right. Thank you, Linda.
Ladies and gentlemen, this concludes today's conference. We thank you for participating.